Let me
broadcasting to all.
invite our trustee, Mr. Lakshmi Narayan, to do the introduction. Welcome, Lakshmi. Request you
Thank
to
you.
start the program.
Thank you, Vanitha. I think it's getting recorded also. It's a pleasure for me to be inviting and welcoming all of you to this webinar of the Chennai International Center on a topic that just before starting, we were discussing. It's a topic that everybody thinks that, or most people think that they know enough about it because there's so much that's been written about, talked about, that everyone has a solution. But I'm sure different ideas and new solutions and new predictions will emerge as part of this panel discussion. The idea is, because this is a webinar conducted on Zoom, we have international participants also, not just participants from within Tamil Nadu, but also outside Tamil Nadu in India and outside the country. So for the benefit of all those, I'll quickly go through an introduction of the panelists and then leave it to Dr. E.S. Krishnamurthy to moderate the complete session. A special welcome to Dr. Bila Rajesh. She is here. For those of you may not know her, she is a very visible member of the Tamil Nadu government administration, and she's been the face of Tamil Nadu government's fight against COVID-19. A very busy person. Welcome, Dr. Rajesh, and I'm extremely happy that you're able to join today's session. Let me add my welcome. Add my welcome to E.S. Krishnamurthy. He's familiar with these type of programs. He's been a regular participant, both as a panelist and as a moderator, as well as a participant in many of CIC sessions. Welcome, ESK. Let me introduce Dr. Sonia Swaminathan. Hopefully she'll join us. She has some time constraint. You can imagine that she's going to be very busy. Dr. Sonia Swaminathan is the chief scientist at World Health Organization. In a recent interview, she is quoted to have said that data is the key to control this COVID-19 pandemic. Perhaps another reason why Dr. Brahma Mukherjee is on the panel today. We would welcome Dr. Sonia Swaminathan. From her position at the WHO, she truly has a global view of this pandemic and the way it's managed in different parts of the world. More importantly, we hope that she will have an insight track on some of the research and experiments and clinical trials that are underway in different countries. And her insights into this will hopefully prepare and encourage us to be what I think it will make us more fearless, perhaps more hopeful, and more participative in the solutions building process. And for those who are not familiar with her, she has worked in research on tuberculosis and HIV for 30 years, was previously Secretary to the Government of India for Health Research and former Director General of the Indian Council of Medical Research. We'll welcome her as she joins this panel. Our next guest is Professor Vijay Raghavan, Fellow of the Indian Academy of Sciences, a Fellow of the Royal Society, FRS, and an Associate of the US National Academy of Sciences. He's been associated with great institutions like the Tata Institute of Fundamental Research, All India Institute of Medical Sciences, National Center for Biological Sciences, Indian Institute of Science, IIT Madras, and of course IIT Kanpur, where he completed his BTech and MTech degrees. Son of an Air Marshal of the Indian Air Force, he has had a career deeply rooted in fundamental sciences. He is the principal scientific advisor to the Government of India, and he chairs the Prime Minister's Science, Technology and Innovation Council that has a variety of national missions, including biodiversity, electric mobility, deep ocean study, and so on. He believes that India has extraordinary scientists and scientific ecosystem in terms of institutions of research and learning, and an extraordinary industry capability, and also rightly so believes that we have extraordinary size of problems that we face. He also is convinced that science and engineering community collaborating with all the researchers can solve many of our problems. I mean, that's the mindset I guess I will approach. I think he'll approach today's panel discussion. And I assume indigenously developing a vaccine for coronavirus and the cure for COVID-19 is among his priorities now. And finally, Dr. Brahma Mukherjee is a biostatistician, data scientist, professor, and researcher. She is the chair of Department of Biostatistics and a professor of global public health and epidemiology at the University of Michigan. For all the participants, Brahma is based in the US and she's looking forward to, very keen to return to India and the current crisis. It's an actor which is relevant for today's session. The Indian study, COVID-19 study group, which is of an interdisciplinary group of and data. This group is presenting very interesting data and vision about the pandemic specific to the Indian context. Her statement that is most relevant for today, this is something, Brahma, I picked up from the reports, the 3-part report that's been published recently. It says, I quote, "It is clear that such draconian national lockdowns cannot go on for months for a country like India or for any nation. We need to think about pragmatic strategies to unlock the lockdown and be prepared for reopening the country. Unfortunately, unlocking the lockdown is not just turning a magic key. The entire world is getting used to the notion of a new normal where we need to be prepared for future partial or complete lockdowns and a pause, restart, drive mode of living, learning, and leading until there is a vaccine." Very, very profound statements coming in that report. And she has been very active in the media of late. She has been quizzed by BBC UK and several others. And I'm sure our moderator will push for the right magic key for us. Let me also welcome the participants. We have a record number of participants who registered for this program. They're all eager to listen to all of you. And finally, a word about ESK. ESK is how we call him. E.S. Krishnamurthy, FRCP, our moderator. He's a neuropsychiatrist with special interest in epilepsy and dementia. He's founder and director of NeuroKrish, the Neuropsychiatry Center. He was the first Indian psychiatrist to be elected fellow of all 3 Royal Colleges of Physicians in the UK. That's Glasgow, Edinburgh, and London. He has done some pioneering work on the interface between brain and the mind. He's a very well-known intellectual in Chennai, participates in many of the activities like this. I welcome ESK and hand over the proceedings to Dr. Krishnamurthy. Over to you, ESK.
Dr. Sonia Swaminathan has also joined. Welcome, Dr. Soumya.
Oh, Dr. Soumya, we're very happy to welcome you. I finished your introduction. And let me also add my welcome to Dr. Ajit Yadav. I hope he's joining in as a participant. And ESK on cue, we say, what do we say? Happy birthday to Soumya today.
Many happy returns.
Dr. Soumya.
Many happy returns of the day, Doctor.
Happy birthday.
Over to you.
Thank you, sir. I think we've had a wonderful introduction, and we thank all the panelists for taking the time off to be here today. And in particular, Dr. Soumya was spending her birthday with us. Thank you very much. We have a set of questions to ask about this very challenging public health problem, which has obviously put the whole world into the most uncharted times that we have seen in this generation. And there are, of course, a number of questions in everybody's mind as a society, including what will happen in the long term, far beyond the lockdown. And hence the title, From Lockdowns to the Long Haul. So it's a discussion we're all looking forward to, and we thank the audience who have sent in many questions in advance. And of course, we're going to try to be as inclusive and try and answer as many of those questions as possible through the discussion. A small organizational point, I would request you to time your questions and use the Q&A section of Zoom and time them towards the end of the discussion, because the questions might have well been answered. Some of my earlier questions are for the 3 professors. and then I will, as we go along, also be asking our Honorable Health Secretary to talk to us about what we are doing in Tamil Nadu. So to begin with, may I ask all three professors, how is COVID-19 different from the previous pandemics? And why must our response on this occasion be different, and how? And I know each of you have a particular brand of expertise, so please do try and educate us from that perspective. Perhaps we'll start with Professor Vijay.
Thank you very much, EVK. This is an extraordinary panel, and I would much rather be listening than speaking. But with that caveat, let me try and answer. We must look at these zoonotic pandemics, that is arising from other animals, in a broader perspective. One view is that there was someone in a wet market who interacted with a bat or had a pet pangolin, and if that didn't happen, all of us would be fine. That is an extremely misplaced viewpoint. And one has to see more broadly why these diseases arise. Zoonotic diseases have been with us for a very long time in a variety of diseases and will continue to be there. About 10,000 years ago, humans, our pets, and our livestock occupied 0.1% of vertebrate biomass on the world. Today, humans, our pets, and our livestock occupy 98% of vertebrate biomass in the world. So we have gone to an incredible level in our interactions with livestock and pets. And they are a very important source of diseases going one way or the other. With wildlife also, our interactions have grown not less but more because of dense population, but also the nature of our interactions. In very many parts of the world, people live in close proximity to wildlife, such as bats. They take shelter in bat caves. They have guano falling all over them. Bats eat fruits or nest in their homes. And therefore, this interaction is regular. Diseases jump across regularly and fail to propagate. But remember, and this is my last point, from an evolutionary ecological point of view, animals such as bats, and there are other animals too, are a laboratory for the incubation of diversity of viruses such as coronaviruses. Because of their high metabolism, they provide an extraordinary reservoir, and because of their immune system, they themselves are protected. This reservoir allows the mixing and matching of the virus in such a manner that the virus generates a whole host of keys through which it can enter the cells of animals such as bats and so on and so forth. Accidentally, through the process of evolution, one key will fit not only bats, but also human. And that one key is what is found by prolonged human-bat interaction or any other animal interaction. An event, no matter how low in probability, is guaranteed to occur if you give it enough time or if the intensity of interaction is so very large. If you buy a very large number of lottery tickets, you are likely to win, or in this case, lose. So that is the evolutionary origin of these kinds of interactions. They are known, they are predicted, they can be prevented or mitigated. There have been warnings on this for decades. So we really need to look at this more carefully. But I would end with one sentence. These kinds of possibilities of zoonotic diseases are staring right in the midst of our big city environments also. Our garbage dumps, our major rivers which have sewage, all sorts of animals going around there. These are places where these kinds of interactions in a manner similar to wet markets are also taking place, and those kinds of jumps can also happen.
Thank you, sir. Can I ask the same question of Dr. Soumya? How is COVID-19 different from previous pandemics? I think we have Dr. Soumya's audio is off, as is her video. Professor Mukherjee, maybe we'll come to you. first and then go back to Dr. Sonia. Could you please tell us how you think this is different from previous pandemics?
Sure. And, I would share my data science perspective that how data has been really game changing, and sometimes in a good way and sometimes in a bad way in this pandemic. So we are living in a time of information revolution where everybody has access to lots and lots of data. So the first thing I'd say that data has been used in different stages of the pandemic, in terms of different phases of the pandemic, in terms of forecasting, right? So when the pandemic with very few cases, how do you project the trajectory of a growing pandemic? So epidemiologic models like the susceptibility infection removal models and the different kinds of state space forecasting models have been used for that purpose. But data has also been gainfully employed in terms of knowing that where is the emerging outbreak to deploy hospital, the healthcare capacity and resource allocation. Data has been used so gainfully in South Korea for contact tracing, for example. The mobile network data have been really used in very good data mining, and machine learning algorithms have been used for contact tracing. So, and then finally, data scientists have been really involved in the labs in terms of prioritizing candidates for vaccines and also running the clinical trial. So you can see this encompassing view of data being used, and that is so useful because when the last pandemic happened in 1918, we did not have this computing structure. So there is a lot of innovation happening in a very rapid speed in the data science space as well. And we have to remember that as much as challenging times are here, whenever we have seen such challenges, I'd like to say that during the 17th century plague, Newton unraveled the mystery of gravity and found calculus. During World War II, Alan Turing started thinking about the computer. So challenges really pushed the boundaries of data science and innovation. And I see a lot of that happening at a very rapid pace. Probably that will lead us to a lot of good things in days to come as we get through the challenge. So I'd like to be optimistic, but would like to be mindful of how in very creative ways data have been used. And as we come out of the lockdown, in terms of the prioritizing the testing strategy, who should we test? Where should we test? What is an optimal allocation strategy? What do we want to estimate? Do we want to estimate an outbreak threshold? So in all of these equations, the epidemiologic forecasting models play a huge role. Would there be a second peak? So in order to understand that, models could be used. But on the other side, I would say too many models, right? How do you synthesize which model is good? All models make assumptions and are wrinkled with uncertainty. So how do you incorporate all of this information in a cohesive paradigm and still use the numerical quantities for a strategic forecasting, as you said, for the long haul? And I would say that data will play a very key role in doing syndromic surveillance as we go forward and keep an eye on the pulse of the epidemic, because we cannot test everybody. So we really have to set up data checks on through temperature maps, through mobility, through thinking about what is the claims related to respiratory illnesses, if there is a spike. So we have to set up, be very data aggressive and data driven as we come out of the lockdown.
There seem to have been three sort of global responses to the pandemic. One response is enforced social distancing and case-by-case testing, which is what India and Tamil Nadu are doing. Another is, of course, widespread testing and proactive prevention, what Germany and South Korea and some other countries have managed to achieve. And the third is go about your business as usual. And we'll deal with it as it comes, which seems to be what Sweden has tried, perhaps with slightly less success than its neighbors, who have a slightly different strategy. Does the science that we have support any of these choices is one question I would like to ask. And the other, what prompted the Indian government choice of the lockdown and what are we learning from that? So perhaps I'll ask the Indian government's choice question to Professor Vijay Raghavan and Dr. Veela Rajesh first, and then come to the science part.
Thank you, EVK. Yeah, so, well, what I will do is, the Indian government's decisions are there for us to see. Let me give you a little more scientifically oriented back end to those kinds of decisions which people take. There are, as you go out of the lockdown, we must first understand what is the purpose of the lockdown. Now, when you have a virus which has very interesting features in that those who are symptomatic spread the disease, but those who are pre-symptomatic and those who are asymptomatic could also be spreading the disease. Pre-symptomatic very likely, almost certainly. Asymptomatic also, there's good reason to imagine that, a good reason to think that that's happening. Secondly, typically, unhindered, the virus would spread to a certain number of people. Each person would infect a certain number of people. And hindered, you can reduce that number. So the question which any country needs to answer is a simple one. How much does the country need to reduce transmission so that it can handle the burden of disease? Does the R0, as it's called, need to be 1 or less than 1? That is, one individual on the average infects only one other person or less than one person, in which case most Indians would never get the disease and there would be time to manufacture a vaccine. If the R0 were slightly greater than 1, then you would have a certain fraction becoming ill. And in an idealized version of this, you would have people over 50 years to be protected, or 60, and the spread would take place only amongst those who are younger, who have lower COVID-19 mortality rates. And this would flatten the curve and protect the elderly strategy, which Sweden has sort of adopted. The problem with these kinds of approaches in a very diverse and complex environment such as India is that even if you pick a R0, as some people have done, which is close to 1, which is say 1.2, this would have a very large number of people hospitalized and very large number of younger people also falling ill, because Indians have many comorbidities such as hypertension, diabetes, and so on and so forth. Therefore, our model has to be out of the lockdown, or whether to have a lockdown, needs to build not only capacity, but needs to also have across scale, which is an enormous challenge, hygiene, mask wearing, social distancing, but also testing and tracking on scale. Testing and tracking is really very important. Korea did that really intensely, and the criticism is that, oh, we are not Korea. We are not Korea, but we have enormous capabilities in doing things on scale, which we must appreciate. We conduct extraordinary elections on scale. We have many things, our vaccination programs on scale. The challenge is to combining scale and speed and quality, and that's what we're trying to do with the government is trying to do with the Arogya Setu app, which is a digital tracking system. Combine that with scaling up the testing, and this testing and tracking of contacts who are also symptomatic and pre-symptomatic would be valid. This requires the extension, the amplification of our testing protocols to include a variety of people more than what is done now. That I expect, as the testing ability and the lockdown removal demands, testing ability will increase, we will start doing that. So in other words, India's model has to take care of our diversity and cannot mimic either Sweden or any of those kinds of models looking for some kind of a herd immunity, given not only our demography, which supposedly is less vulnerable, but also one must keep in mind we know very little about the way it affects a younger demography in our context, given various other comorbidities.
Thank you, sir. If I can quickly ask Dr. Veela Rajesh what the Tamil Nadu experience has been with the lockdowns, the testing, and the tracking strategy?
Yeah, I think, thank you very much. Professor Vijay actually summed it up very beautifully. I think that was the right strategy that state government as well followed. In fact, the whole country went together as one. And as far as Tamil Nadu was concerned, we started the screening very early, and we started the sensitization as well. We had a huge, one big cluster, which kind of helped us to upscale. We used the time as was advised to sensitize, to build infrastructure. We needed to step up our lab testing facilities. So we went from 0 to 44 today. And we went from a capacity building also for testing to almost, today we are able to test about 10,000 per day. So I think, and the whole government machinery, thanks to all these decisions and the expert advice, everybody was tuned into chasing the virus. So that helped to a large extent, because every district collector, every corporation commissioner, everybody was involved. All departments were involved uniformly. Common methodologies were worked out as far as the containment zones are concerned. And it was a very successful way of going about containing the virus, stopping the transmission, and ensuring that we buy time.
Thank you, ma'am. Professor Mukherjee, you're looking at this from an international perspective, and you're seeing different strategies being adopted by different governments. Your data science approach, what is that telling you about which strategies may be more helpful, or is this going to be more local rather than one size fits all?
So first of all, I want to echo what Professor Vijay said, that in a very beautiful way, that India's solution is going to be a very creative solution. And I think every state has its own solution, and every region and community has its own solution. As we are thinking as a university even, we have our own set of unique solution about what is the optimal way of reopening. But I think there are some common basic principles that we know. We know that we have a finite number of tests. It is probably not realistic that we are going to test everybody in India every 2 weeks, or even 1% of the population every 2 weeks. So we have to be really focusing on what are some proxies for testing. How can we incentivize the public to come forward when they have symptoms? They are not afraid of losing their livelihoods or stigmatized. So I think we have to generate that awareness. This is a pandemic where the government cannot do the work alone. You need strong partnership with the public, with the scientists, with the policymakers, and you have to really work with united resolve. So I'm thinking as a data scientist, what are the proxies that we can set up? We can ask people to, of course, report symptoms, and institutions are making symptoms reporting a sort of a mandatory guideline for many of the institutions. And then we can ask people to maintain contact diaries. If we are not that invasive into getting everybody's data and credit card information, which South Korea did, and instantaneously within 1 or 2 hours, they have this algorithm which informs people that you should get tested. So for that, we need a large accessibility of tests. So I do not know whether that's feasible, but we should really encourage people to maintain contact diaries so that you know who are the people you regularly interact with. Organizations really need to think about, so if you think about the model, there is a susceptible compartment and the infected and removed. So you have to reduce that, weaken the arrow from the susceptible to the infected. What are some strategies to do that? In an organization, you have to think, what are your critical functions where you have to be coming in close physical interaction? What can we achieve in an optimal way using network theory? That what are some of the edges and the connections that we can drop and still maintain the morale and functionality of an organization? So I think it has to be really creative, and everybody has to be engaged and committed to ensure that, places of common where you interact, common interaction are disinfected regularly. And people are, so we have to be prepared that this is the new normal, that we are all going to wear masks, we are going to protect each other, practice hygiene, and interact in spaces, and minimize physical interaction, but still try to keep the virtual morale high. So I think it is going to be a really combined strategy where economics and public health and policymakers and all the society come together and try to minimize the collateral damages on every front and take a utilitarian perspective of minimizing a global utility for the public and minimize human suffering and loss.
So from the international perspective, you do see the Indian strategy as being appropriate for a country as diverse as this and as populous as this.
So, you know, this is very interesting because this is the world's biggest field of natural experiments going on. So, and everybody is choosing their own strategy. And I have to say, I'm really, really impressed by South Korea's strategy because they actually achieved getting rid of the virus without a lockdown. But they used aggressive data and invasion almost into privacy for contact tracing. So there are issues with that, whether a country, there are privacy issues, there are ethical issues. But you see that different countries have adopted. New Zealand, for example, has a different strategy. South Korea has a different strategy. And many places, they don't have a coordinated strategy and they're suffering. So one thing I can tell you that you have to respect the virus. You cannot really take it very lightly. So a combined strategy of modulated release with many of the social distancing and preventing that transmission, maybe we'll have suboptimal mitigation because we cannot be in lockdown forever. But then we have to strike a compromise between what is the optimal, how can we minimize the chance of transmission, given that we need to reopen the economy and start reactivating the workforce. So, and then it's like, you know, no other, so I think we have to learn from the world and take best of all the strategies and come up with our own in order to, and tremendous work is going in India. And I'm just so impressed by the work that everybody is doing together. This has really been a phenomenal natural experiment to watch. And I think the last line of the Medium article, I actually said that India's example will probably be an exemplar model for low resource setting, how to really battle this pandemic.
Wonderful. It's very, very heartening to hear that. Just moving on to treatments. So many preventive and curative treatments appear to keep coming up in the pipeline. So there's been talk about hydroxychloroquine, remdesivir, plasma exchange, BCG, both past vaccination and the use in adults, rather controversially, oxygen therapy, thrombolytic agents, steroids. From a science perspective, Professor Vijay Raghavan, are we close to thinking that any of these treatments are going to be useful either as prevention or as treatment in the outpatient phase or in the acute phase? Do you have any thoughts about this?
Yeah, thank you, Viveka. This is a very interesting question. Of course, as citizens at the receiving end of the virus, we want solutions and we want them fast. But we must keep 2 or 3 things in mind. One is the biology of the virus. We don't know a lot, but we do know many things. So that balance is over there. From the view of what we don't know, there is a tendency in terms of therapies to throw the kitchen sink at it and see what sticks. Now, that's okay, but the expectations from such an approach should be very, very low, number one, because, I mean, it's very unlikely you'll turn lucky. Secondly, even if you have a belief that something will work and you want to try that out, you must ensure at the least that it doesn't cause harm, even if you don't know whether it's of benefit or not. That is a big challenge. So many people have many beliefs. I know this will work, or that will work, or why don't you try this, and so on. You already are prescribing X or Y or Z, right? But are you sure it doesn't do harm? That's why randomized controlled trials are necessary even there. And those next set of, potential solutions are those which have some sort of evidence basis from other experiences. Now, hydroxychloroquine, for example, we know that it was an anti-malarial drug, but has effects in rheumatoid arthritis and in lupus. And one of the reasons why it has an effect is that it alters the acidity of intracellular compartments. And the virus, in this case, has to have a certain acidity for it to passage through those compartments. And the hope is that perhaps the effect of hydroxychloroquine will affect the virus. Now, randomized control trials are going on globally. Their indications are that it does not work as hoped. So again, even though it's a drug which you can prescribe, we must remember it's got side effects, and therefore its use, if at all, even on hope, should be very carefully done. Remdesivir is another kind of drug. The virus, these viruses typically substantially use our host machinery to replicate. And therefore, drugs which affect the virus will affect our host also, affect us. But remdesivir acts on a virus's replication and makes sure that virus normally makes sure that it replicates itself precisely. And remdesivir affects that process. So that it could have an effect. Now, there are two kinds of trials which have happened. One, a trial in China by Gilead, where the numbers of people involved turned out to be fewer than what was needed. So effectively, it was an underpowered trial. And in that underpowered trial, you did not see a benefit. So if you had seen disproportionate benefit, even in the underpowered trial, there was some hope in terms of mortality for that to go ahead. Now, there's another trial which was done in the US in which the end point was mortality, but that end point was changed to look at period to recovery. And there was about a 30% benefit in a powered study for period to recovery. Now, some people argue that this is a foot in the door, and this drug can now be constantly improved and a cocktail made with other drugs, such as happened with HIV, that eventually we'll have a powerful drug. That takes time, that's the hope. So that's the more directed approach. And third is completely new drugs, which are much more challenging. Vaccines are proving much more promising, and there are over 100 attempts all over the world. There are at least 10 or 12 in India, both indigenous studies and collaborative ones. And so far, it doesn't look like the vaccine approach will have huge pitfalls. In other words, it's going in an extraordinarily rapid way as never before. And so far, touch wood, doesn't seem to have a major biological roadblock from the point of view of being effective against the virus.
And with this being the case, would the Indian government be encouraging fast clinical trials? And are there clinical trials ongoing in India which you are very hopeful about?
Right. I mean, let's take the example of vaccines. Typically, to make a vaccine against a viral disease takes 10 to 20 years and costs $200 to $300 billion. If you want to do it in 1 year, you have to do many other things. It'll cost about $3 billion, and it's a big challenge. One of the principal ways to do this is instead of trying out a few candidates, you try over 100. That's what the world is doing. And you start, in parallel, manufacturing vaccines and stockpiling them, even though you don't know whether they'll go past clinical trials or not. That's huge risk for companies. And therefore, that risk mitigation needs to be done in parallel. People now have regulatory protocols, both in India and abroad, which skip animal trials of certain kinds. Those kinds of trials were done in the past, accumulating regulation upon regulation, some aspects which were necessary and some aspects which were there just to reassure everyone. And there was a lot of excessive regulation that's being trimmed. So that's happening. Instead of having population trials, there is talk about challenge models where you make a vaccine and you infect volunteers with the virus. That raises extraordinary ethical questions. It's not yet clear whether that route will be taken, but that can shave off from 6 months down to a month in vaccine development. So it's incredible to see the world coming together. There's also India, by the way, has got one of the world's largest vaccine manufacturers, many of the world's largest vaccine manufacturing companies. A child anywhere in the world who gets vaccinated has 2 out of 3 vaccines made in India. So in terms of manufacturing, India will be certainly a big player. But what is exhilarating from a scientific point of view is how many Indian companies and startups and academia have come into the early stage of vaccine development. So that's very good.
Very heartening to hear, sir. Professor Mukherjee, if I can ask you the same question, looking at it from a global perspective, is the data pointing us towards any particular treatments at any particular stage, or are we to wait for a vaccine?
So I would have to say that I actually have nothing to add. Professor Vijay Raghavan has, and I'm not an expert on the clinical trial part of it. I have been looking at more of the epidemiology and forecasting models. But I have to say that just like testing, there will probably not be enough vaccines for a long time. And we have to think about prioritization. Who do we vaccine first? Which countries do we give more access to? Because there's going to be a big data-driven issue. And are we going to protect the vulnerable, the frontline health workers? And, just like we are thinking about who should we test more often, that's the one who are at the highest risk of the disease. So we need to do a lot of work on risk stratification by labor shared, by occupational sectors, frontline health workers, comorbidities like hypertension, diabetes. And another thing is that what we are seeing that there is in the US, at least, there is a strong racial difference in terms of the outcomes, particularly in terms of morbidity and mortality. So genetics might have a role to play, and we are learning about this, that where the ways that which treatment will have most efficacy may not be one size for the population. Maybe there are substrata where the efficacies are different, and you have to come up with more targeted approaches. But I think that we have to think about this prioritization question too.
Thank you. We now have Professor Sonia Swaminathan with us. Good afternoon and happy birthday.
Oh, thank you so much. Thank you.
We'll wait for you to put your earphones on.
Can you hear okay?
Yes. So wanted to ask you a question from the WHO perspective of the different approaches that various countries are using. Which ones do you see working best? And in terms of easing lockdowns, which is important for the economy, what is the WHO view on that?
So the thing is that WHO really never talked about lockdowns. This was something that countries decided to do. We only talked about physical distancing and other public health measures. So the approach has been to basically try to identify the cases. And in the initial weeks, we were focusing on containment. So if you could detect, isolate, and treat the infected, and contact trace and quarantine the contacts, then there was a possibility for a few weeks where you could actually have contained this infection. But because of the nature of the transmission, I think because it's so highly transmissible, and it also transmits from people before they develop any symptoms, this got out into the community in many countries. And probably now we are past the stage where you can have a full containment, the way that SARS was contained. So I think we have to have a combination of strategies where countries have to accept a certain level of infections with COVID, but then keep it at the level where the health system can deal with it, where it doesn't overwhelm the health systems, and where both the infections and the mortality is kept at a reasonable level. So the country needs to define what that limit is and where they should get alarmed, and put in place surveillance mechanisms to keep track of what is happening in the community. So these kind of sustained lockdowns, I think, in countries like India are going to lead to enormous collateral effects in terms of really impacting on other health systems, and perhaps increasing. Some models are saying mortality due to other diseases may go up 10 times. And this is just the health system. And then you look at livelihoods and what's happening to people who don't have enough to eat and so on. And it's very difficult, but I think an informed decision needs to be made on how much lockdowns really help. The other issue, I think, is what does a lockdown do in an urban slum or in a high density situation? Does it really have the impact that it has in Europe, for example? I think the lockdown strategy started in the high-income countries, where people have houses where they can isolate themselves. If you're talking about an urban, high-density environment in India, that concept doesn't exist because people do not have spacious homes. There are 10 or 20 people to a house. And even where they have to come out to communities for common latrines or common water sources or for common sourcing of whatever they're buying, etc. And so really implementing physical distancing is impractical. So I think there's now a realization that you need, and even WHO, I think, now is putting out some guidance on what do you do in these kind of settings. But I think India has an opportunity to really leapfrog and develop models which are more suitable for the kind of situation, because otherwise we'll never get out of I don't see how we'll ever get out of red zones in any of the cities which are currently in red zones. There is going to be ongoing transmission, and the goal here is not eradication. So I think that the discussion really should be around what do we try next, and how do we monitor and measure that, and what systems do we put in place.
Open this to Dr. Bila Rajesh. From a state and a health administration perspective, how do we take those perspectives on board? Because we certainly need to restart economic activity. We need people to allow people to restart their livelihoods. As Professor Sonia Swaminathan has been saying, many people are very concerned about prolonged lockdowns. So what has been the experience in Tamil Nadu? How do you think we may change strategy as we go along?
We have been fortunate to have Dr. Soumya advise the Honorable Chief Minister as well. So I totally agree with what she's saying. And I also agree with what Professor said earlier, that we need to be having a very dynamic kind of strategy. Because to begin with, it was an imported disease. And to begin with, we did need to have some sort of a lockdown to sensitize the common man. Because it's a highly, like it was already said, it's a very diverse population that we are dealing with. And so I think it needs to be very flexible. We did need the zones in order to make people understand the seriousness of it. And this zoning and these containment worked very well, in fact, in some of the rural areas. But like the Dr. Soumya Swaminathan just said, yes, it's time to now shift. We need to strike a balance. Now people do know about the disease. So we need to keep shifting and changing and work out the optimal levels based on certain objective criteria. I think we should keep changing, and we need to get the economy moving as well.
Thank you. So in terms of, Dr. Soumya, I know your time is a bit limited today. So just in terms of the priority areas, is it going to be a biological understanding of the virus being better that is a priority? Is it an understanding of curative treatments for people who are infected and symptomatic? Or is it an understanding of prevention? Where do you think the focus really has to be? And is that differential across countries?
Yeah, that's quite an interesting question. And I think that each of those is important. For the time being, till we get a vaccine, and it's not just getting the first vaccine that's effective. Of course, there's a huge push now, a global push, and WHO is part of that, to try and get a vaccine, or actually, ideally more than one candidate vaccine that's effective. Let's say that takes us very optimistically 9 to 12 months. We'll have a few tens of millions of doses available probably for so we need to prioritize who gets that. Most likely it should be health workers who get it first. And then there'll be, in the following year, maybe hundreds of millions of doses. But if you need billions of doses, this is going to take a couple of years. What are we going to do till? And then we have to, all of those other caveats about the cost of the vaccine, the availability, the health system being able to vaccinate everybody. All of those big major challenges are there. But let's say all of that is, let's say by 2022 or 23, a large proportion of the vulnerable population is vaccinated. What do we do from between now and then? I think we need to understand more how the virus is spreading in communities. It's good to learn from other countries and what they've done, but I think every country has to look at their own data and really needs to interrogate their own data to see what is happening. And expand testing. I would say for India, we need to expand testing so that we we are confident that we're covering as many people as possible. The indicator that WHO is proposing is to do at least 1 per 1,000 tests per week, which means a huge number of tests as far as India is concerned. We're also proposing a few other indicators. It should be out on our website a couple of days, how governments can monitor what is happening. Doing monitoring of influenza-like illness, ILI, and severe acute respiratory illness, SARI. If those rates of COVID positivity in those cases, in those syndromes remain less than 5%, that's an indication that your COVID is not going to go out of control. So one has to keep a critical eye on those indicators while allowing when you allow things to start up and open up and go back to normal. It's also been modeled that you could have 10 times more deaths due to other health conditions than COVID. So you may be able to save every last COVID patient, but then you're losing a lot of people to TB, to diarrhea, to pneumonia, and to heart attacks. So we have to keep that in mind. We have to balance that. And finally, I think people will need to be participating, and you have to get people's buy-in. Coercion is not going to work in the long run. You can put Section 144 and all that for some time, but after that, people will start rebelling against that. The only sustainable way is for people to understand why and what they're being asked to do and why they are being asked to cooperate. It's again very challenging to avoid stigma and panic while still allowing that space for communities to take charge of how they want to handle this. So I think we really need to take it down to communities now. I think there's no other way. It's going to be different in rural and urban areas, but communities need to figure out how they want to do this, how they self-isolate, how they self-report cases, because they understand that it's for the larger good. And if they self-report, then they need to also be assured that they will be economically not starving, right? Their families won't be starving if a daily wage worker self-reports and is put into isolation for a month. So the government will need to assure them that the families won't starve. So I think it's these kind of issues that now need to be discussed as we think about longer term, because the lockdown is really a very stringent and a very unusual mechanism that cannot last forever. It's the post-lockdown strategy without community engagement and participation and complete buy-in and forming a trust between the government and the community. We're not going to be able to solve this. So what the next steps I would think are to really go down to the community and ask each community to do risk assessment for themselves and find local solutions. Where do they want to isolate their positive cases? Where do they want them to quarantine? What would they need for that to happen? Will they all agree to wear masks? Will they agree to self-report if they have fever? Knowing that it's not going to be a punishment kind of a situation. And can we keep stigma low while all of this happens? We don't want neighbors reporting on each other. And in some states, the police have been asked to go house to house to do this. Perhaps the police force is not the best idea. But we do need a force. And I think Tamil Nadu is thinking about creating a workforce just to do this kind of public health surveillance.
Thank you. In fact, one of the things that India used quite well for HIV prevention was health behavior change communication, developing models and making sure that those models were well disseminated. Are any of the panelists aware of such models evolving? Are there structured models that are coming up that can be used not just in this culture, but perhaps in other cultures?
Well, Sonia, of course, is very deeply familiar with this. The National AIDS Program, the TB program, the polio vaccination program, all have extraordinary community roots and huge national reach. So it's not that India is inexperienced in this kind of a reach. The challenge is to partially repurpose them to allow them to be built for this purpose without compromising the many other demands on disease surveillance and action, which communities also simultaneously need to do.
Thank you. Sonia? Would you like to add to that?
Yeah, no, I totally agree with what Vijay said. I think we have experience and we've done this in the past. So it is completely possible to do it. We're going to need additional resources. So to think that you can do all of this with existing resources, I think is not realistic. It's also an opportunity for us to build this public health infrastructure in states which do not have it. Tamil Nadu is probably an exception. Tamil Nadu has a public health department. It's one of the few states, I don't know, 2 or 3 states in India that have. So I was on the phone with the Chhattisgarh health minister earlier, and I was suggesting that they create a public health. This is the time for them to do that. So I think it's a time for states to build their public health infrastructure and the primary healthcare system, which will help in the long run as well. So let's use this pandemic to actually build something that we needed. The surveillance systems, the medical cause of death certification. We have very poor data from medical cause of death. So in India, we cannot analyze our death data to know what people are dying of and where, and so that you can balance your resource into those diseases which have the highest burden. These are very basic things which every country needs to have. In the UK, if you listen to the BBC every night, the Office of the National Statistics puts up the extra number of deaths that they've seen on a day-to-day basis, and they're able to say how many were COVID and how many were non-COVID. We're very far away from that. So I think we need to think long-term as well as short-term, and start investing in those things which don't exist today. There are models of countries which have done very well, and the 2 that stand out, or the 3, are Taiwan, South Korea, and Germany. All very different approaches. The Taiwanese people were used to SARS. They had experienced SARS. And if you listen to some of the just ordinary citizens that were interviewed, they say we have huge trust in the government. We obey. We don't ask questions. We do what the government tells us to do. So they say wear masks, maintain distance, we do that. Self-report, they do that. It's a different society. Sweden has done a similar thing. They, of course, very low population, very high trust in government. People follow a highly educated, literate society. They didn't have to impose anything. They just asked citizens to do certain things that were done. Germany followed the approach of massive testing. Just test everyone who has any symptoms and their contacts and isolate them. And South Korea did the same, massive testing. These are 2 countries which have kept their deaths and their cases very low. So India is different, of course, and different parts of India are different. So we have very different challenges. So states will have to figure out now, I think, what the best strategy, and urban and rural is going to be different.
I know that we are all on a short timeline. Before we go to Q&A, I have a couple of quick questions to ask. Dr. Bila Rajesh, could you the perspective of a state that has a reasonable public health system, what do you think are the 3 most important elements that could be put to use in order to move from the lockdown to the long haul in Tamil Nadu? Maybe those best practices can also be adopted elsewhere.
Yeah, so one important thing, as was already discussed, is of course the data. So we've had a chance now to analyze exactly how clinical symptoms have played out in Tamil Nadu as far as the disease is concerned. In terms of, we've had almost 80% asymptomatic and only around 20% of the symptoms. So this gives us a fair idea of what we need to build into the health infrastructure post-lockdown. So that is something we are definitely looking at, the health infrastructure in terms of equipment, materials, and basic cots and availability of hospitals. The second most important thing is, again, having the foot soldiers on the field. So we are going to need additional field staff in order to keep up the surveillance work. So that is the other thing that I think we are looking at building up, along with the technology and data. I think this is the era of technology, and we should harness this technology usefully so that people are able to, have a normal life, and at the same time, we are able to effectively tackle the virus so as to ensure that the mortality rates remain low. I think this is the way I look at as the most important factors right now.
Thank you. And Professor Mukherjee, I know that you have a lot of data with you, which you have been analyzing. Are there key elements that you'd like to share before we start taking questions?
So, I was thinking about sharing my slides, but I think in the spirit of the question and answer, we should I see 32 questions in the Q&A section as well. So I'll probably let this free flow. But I'd like to echo something Dr. Swaminathan said about the building the public health capacity and the task force. I think in the US also, I think by building this and employing people, you can also address some of the challenges with the economy. So you can actually, this can be a dual-pronged approach where you create new jobs, but also build the public health infrastructure. And I think we are in this. I would really like to emphasize on the long haul part of the title of today's webinar, that it does require a long-term, prolonged, sustained strategy. We cannot be impatient. We cannot give up. And we have seen so much success right now. We have seen that social distancing has worked, and humans have really beaten the models and the dire projections. And I say this as a modeler, that I'm so happy that those projections did not come true, because the interventions have worked to some extent. But I think that now it's a utilitarian mechanism of really balancing between the composite utility of saving lives and saving livelihoods, and also taking a more holistic approach as a community-based solution. I think is very important to tap onto the grassroots level strengths using community health workers, and also create the social morale that we are fighting this together, and there is no stigma in getting infected or reporting infections or being in close contact with cases. This is going to be extremely important. But I think the 333 principles of test, trace, and treat. And I think we are at a point, if we come to the lower end, the tail of the incidence curve on the decline, then if we can contain those new cases and really put a surveillance on the upcoming resurges that may come and contain them, we'll be in a good position. But we cannot underestimate that this is going to go away. We definitely have to be on high alert.
Thank you. So we've been kind of assimilating the questions, because we know that we can't possibly ask every question. We already have about 34. So I'm going to put some assimilated questions. We've had, Professor Vijay, we had quite a few questions about the role of traditional medical systems, people wanting to start clinical trials. One particular thing that has come up a lot is ozone therapy, and people wanting to start trials and being willing to fund those trials, provided the government is able to encourage them and support them. Do you see these efforts as being possible to do, and what is your view on that?
Well, let me answer a more general point. There needs to be research and clinical trials on many, many aspects of the disease and its spread, the recovery, and the way we are handling it. So that needs to be done in our environment. To do that, the government has constituted a vaccine and COVID-related R&D task force headed by Professor Vinod Paul and myself. And we both top-down suggest research areas for work, and if there are, and we facilitate bottom-up mechanisms also. The force, the EMPOWERED group, separately headed by Dr. Vinod Paul, has published a set of research guidelines of how clinical research can be done. Those require the statement of protocols, what you want to do, why is it meaningful, put that through proper committees at high speed, and get going. So coming to specific suggestions, therefore, as I started by saying, it's very valuable to throw ideas at the disease. But if you want to do trials, they need to be translated into hypotheses, protocols, methods, how you would do that. And all that is in place now. So those people, hospitals, researchers who want to try something should follow that route. So
you would encourage efforts, but you think those should be regulated efforts and well-planned and well-organized efforts. Professor Vijay, to summarize.
Absolutely. The bar for quality need not be reduced, should not be reduced in the need for getting a quick solution. And that really requires high standard trials, whether it is proposed by individuals or proposed by big companies. And that really needs to be there. Otherwise, there's a great danger that we will waste efforts in ideas which are not mature or which are not rigorously tested or testable.
Thank you, sir. Professor Mukherjee, you, I think, alluded to this, the whole privacy versus data management, data acquisition and management debate. Where do you think the line should stop in terms of people being monitored and data being gathered and collected, which is very important, of course?
So I think that data has been used in various different ways, and it has been quite inspiring to see the creative use of data. And of course, with the use of data, when you are really tracking your mobile data, there comes the concerns of privacy and ethics of it. I think it has been used in South Korea to ensure that social distancing guidelines and quarantine is being followed when someone is supposed to be quarantined by just looking at the geolocations of the phone. And also because the phone can be sometimes right in your, I have heard from some of my friends in South Korea and colleagues that the phone can stay in a place, but the human beings can move around. So there are often calls to check that you are with the phone or not. So this is considered probably an extreme level of invasion. And so I think that and also it requires a huge number of people employed in the IT sector to do this kind of geofencing and geosurveillance. But also then giving credit card information to find out, and that's probably is going to be a challenge in many, many countries, that just not the phone data, the credit card data to understand where the purchases have been made and where the case has traversed through, and to alert all the people in those locations that there has been a case who has, and then get those community tested. I'm not sure that level of invasion is actually possible, but again, I think it's the buy-in from the public. Any strategy that you take, I think you have to make it clear. Wearing masks may be challenging to some people, but when you understand what you are doing, it's not just protecting yourself, protecting others, and the benefit that you are having on society, I'm sure there will be more buy-in. So I think there has to be a ground-up approach right now, that any strategy and solution that you're rolling in, you have to not imposing, but really get people buy-in that, yes, if I actually donate this data, this is going to be for a greater good. So if you have that momentum, then in big metros and hotspots, you may be able to roll this out to understand the pulse of the pandemic. But I think as it was articulated throughout this session, that there will be a combination of different strategies, some very information technology and tech driven, some door-to-door survey of symptom and temperature taking. I don't think that we can forget the ground principles of public health as we think about data driven. And I'd also like to really iterate that the quality of data. I think any model, projection model, allocation model really depends on the quality of the data. So it's incredibly important to have accurate case counts and cause of death and death counts due to COVID in the medical records and mining those medical records. So I think we can be intelligent and maintain a balance between public support and not to intervene or invade too much, but also innovate. So that would be my answer on this.
Thank you, Professor Mukherjee. Dr. ASK, I think Dr. Bila Rajesh has to leave in the next 2 minutes. So could we direct some questions for her, if any?
Yes, in fact, I was going to ask about the contact tracing strategy in Tamil Nadu and the active, search for cases, how that is being carried out and what results it is yielding is one of the questions.
Yeah, contact tracing here actually there are multiple levels are working at it. One was we started first getting even data first when it was just international travelers. We had gotten immigration data from other states as well, and there were field level workers from the panchayats and revenue officials who went and did door-to-door survey, questioning and things like that. And that is still happening along with the health department. There are teams that go and do that on the spot, going and questioning and asking. Other than this, we also have the police department using telephone contact details and even, mapping telephone numbers of those who were nearby that positive case. So that is the other way. The technology is also being used for contact tracing in depth. And the second question that you asked me was regarding
how successful that has been, and how you're acquiring knowledge and data about cases.
Yes, it was very good. In fact, during that cluster that we had, it really helped us to come out. And then we also gave a public appeal. The Honorable Chief Minister himself had appealed to people also to come forward. So many people did come forward themselves and submit themselves as contacts and tracing. So it was a combination of all these three, and it went a long way. And I totally agree that I think community participation is the key. And this lockdown, in fact, has helped us to do a lot of sensitization about the disease, and also telling people not to stigmatize and to come forward and help us with contact tracing. People's participation has been the key.
Thank you, Doctor. It's very heartening to hear that. Thank you so much for your time and participation.
Thank you so much. It's been a wonderful evening with all of you. Thank you so much.
Thank you, Dr. Bila.
A question for Professor Vijay Raghavan. Is contact tracing using the Arogya Setu app a practical solution post-lockdown? And what adoption of population coverage is needed for this kind of app to actually work?
Okay. The first point is about, is that feasible? And secondly, what level of coverage is needed? Now, the feasibility is an important question. There are several 100 million smartphone users in the country. And right now, if I'm not mistaken, about close to 85 or 90 million have downloaded the app. So that's enormous. Now, in addition, there's a feature phone version, which allows a integrated voice response system so that you can call up a number and get a response, and that's going on. So you don't, even if you don't have a smartphone and you have a feature phone, that is can be used. Thirdly, there's community interactions, community workers with phones going around the community and getting feedback on hotspots, what's going on, and so on, and talking to individuals. And so this combination, what is depending on the balance of different kinds of instruments, needs to be scaled. The start of the Arogya Setu app was just a very simple functional one. You gave in your personal health information, are you diabetic, hypertension, travel history, and so on, age, and then had your Bluetooth and GPS on. And if someone were to be tested positive, then the app went back in time and identified those who were in contact with that person, proximal to that person, and told them, depending on their vulnerability, their proximity, what they should do. This is very, very critical, because the way the disease goes is not just by symptomatic people, but by asymptomatic people. So the speed of contact tracing and identifying asymptomatic contacts and pre-symptomatic contacts is very important. It's already proving to be successful in many areas, and this needs to be scaled up. This is the classical contact tracing going digital. And if you have, the calculations have been done, if you have something like 60% of the people using this, and there were no asymptomatic transmission, you would get something like digital herd immunity, if this were done fast. But there is asymptomatic transmission. And then you can calculate how much benefit you have by increasing usage. Below something like 30%, you don't get any payoff. As you go above 30%, you start getting payoff. If you go to about 80-ish%, you start heading towards digital herd immunity. So those are the ranges possible, and it will work well in our diverse country in different environments, in differentially, in shopping malls or in trains or in factories that would have one kind of an effect. In big urban environments, such as in Dharavi, it would need to be done in a different way. And that's the attempt. And as you know, Ramar has said, as Soumya has said, it's absolutely vital that community participation and involvement is there. To end, we hope for the plan of having a drug and a vaccine to come out. You heard from Soumya how long it takes. Before that, if we have to be effective in our own complex context, we need to have masks and hygiene, social distancing in an innovative way in our context, testing, tracing, and isolation done in a manner which bears community involvement into it, as well as understands the complexity. A big challenge, but it's, I think, given our diversity of talent and abilities, it's feasible.
Thank you. One question to both of you, and Dr. Soumya when she comes back, is what about this pandemic justifies such a drastic response?
Ramar?
What about this pandemic justifies such a drastic response?
So first of all, I think that there was a lot when this pandemic hit us in March. We knew actually very little about this virus. So essentially, this lockdown and that drastic measures that were taken were to buy us time. Can you imagine the progress that we have seen in terms of the knowledge inventory about this virus in the last 2 months? So in terms of vaccine, in terms of treatment, in terms of how this virus actually transmits and how community transmission can happen, the person-to-person transmission, the person-to-object transmission, it stays on a surface. So all of these new experiments that have been going on, and the whole world is working in a concerted manner to get that knowledge. And the whole key thing is this transmission by the asymptomatic. In flu and other illnesses, when you start seeing symptoms, and that's when you are most contagious, so it's easy to say that I'm showing symptoms and I can say that I'm going to self-quarantine, or somebody else, my physician, can tell me. But when silent infections are a huge part. And now with the antibody testing studies, that's something we have not talked about in today's webinar, that we are finding that a large number of people were potentially infected. And that's why it got so bad potentially that they transmitted the disease. It's also important that this is a very interesting, because even as a mathematical modeler, exponential growth is something that we are not used to. We are always used to linear growth. If you think about we had 15 cases at some point of time, not too long ago, 2 months ago in US, and where we stand now. So this has been sort of a failure of our collective societal imagination. So it just really dawned on us. So it was extremely surprising. We knew very little about the virus. Some of the outcomes are very lethal. So you see that it's initially we thought it was only in a vulnerable population comorbidities, but we have seen some strange deaths in US in terms of younger population, blood clots, strokes. And so the whole manifestation on the disease realm was also unknown. So I think that we really needed the time to study so that we can build, like when it came as a tidal wave, we had a picket fence, and we used this time to build the dam and the escape boats, and so that we can really fight this. So I think that's one of the reasons, because there are so many unknowns. But I think that this is also the contagion part, and also the severe outcome part, the mortality and the rate of ICU admissions. And from people who actually go to ICU, the mortality rate is extremely high. So in absence of enough ventilators, healthcare capacity, this was really a very stormy and gloomy sky that was looming on us. And we had to react, and we had to protect the human race. So I think
you do feel it's justified by and large.
I think it is justified by and large. And the problem with these interventions is that every time the interventions work, you cannot observe the counterfactual. What could have happened without these interventions? So people say that the policymakers overreacted. That's the challenge for policymaking today, is that there is no way, and thankfully you do not know what could have happened without the interventions. But I am on the side of now, balancing between mitigation and reactivation of the workforce. But I think this was needed. This was really needed to buy the time.
Professor Vijay.
Well, this is very nicely put, Brahma, and let me comment from a complementary perspective. It's not that something happened and we just imagined that it will blow up and let's shut the world down. we knew very rapidly, albeit, points that it could have been done even faster. We knew very rapidly what was the nature of the disease and what caused it. Atypical pneumonias, which happen in certain kinds of environment, are causes for great concern. Public health people watch out for those. Those are the dangerous kinds of things which can spread very rapidly. Secondly, when you identify the virus and you know it's a coronavirus and it's a new virus, alarm bells start ringing rapidly. When you see human-to-human transmission, then those you know it's a new virus and you see human-to-human transmission. You really get on your act really fast. So these are things which point out from a scientific perspective that you have to be careful. That combined with the power of the exponential, it is just very, very critical to understand that. A very beautiful story to illustrate that is the king who promised his courtier, 1 grain for rice for the first chess square, 2 for the second, 4 for the third, 8 for the fourth, and so on. And then by the time you went down, you had basically emptied the entire granary. So you must understand the power of the exponential, which very few of us appreciate. And therefore, reacting is really very important. There was basis for that. And finally, it is better to be more careful and accused of being more careful than accused of being careless. Let me give you one example. In Marseille, during the plague, a ship came from Lebanon, and it was supposed to have a 40-day quarantine before its goods were unloaded in Marseille. The traders of Marseille said, come along, no big deal. Instead of 40 days, 10 days is enough. Within 2 years, half the population of Marseille was dead. So, it's important to keep a sense of perspective. Other places, did differently. Brahma pointed out that we don't have the counterfactual now, but we do have examples in the 1918 flu epidemic between Boston and Philadelphia, how different cities reacted and how one messed up and the other didn't. So, these are very important examples.
And I have to say, I have to add to that this is something that has been really growing in my mind, that as I'm seeing more cases where I have personal experiences with the families in US, that it's not just the statistics, it's human lives we are talking about. It's not just like, 60,000 people, it's families, it's communities which are being completely destroyed and in great grief and pain. So we cannot just do everything by numbers. And these are human lives we are talking about. And all the model projections showed that what could have happened. And you have seen that in many countries. And I think we can take the approach that you are going to let your life go on and aspire for herd immunity. But that's, in my own opinion, it's not the right strategy here when you can save lives and balance between lives and livelihoods.
So 2 final questions to both the panelists. The first, we've not talked about herd immunity and herd effect. Herd immunity, of course, is probably going to be difficult until you have a vaccine. But what about herd effect, and what are the predictions about how long that's going to take for to evolve and develop with the population?
Brahma, would you like to go first?
No, probably you go first, because I do not want to make such promises.
Well, there is actually a very recent and very nicely done analysis of these kinds of questions, both in UK, where this was formally structurally debated, and in a more general context. And that was done by Professor Devi Sridhar of the University of Edinburgh. And Devi pointed out very nicely about how one must be careful on using herd immunity as a tactic for this disease, where we do not know many, many things. The nature of the immune response, the extent of the immune response, the period where the immune response lasts. And therefore, to proactively say that I will open the doors, let my young be infected, and let's have a herd immunity, isolate the elders, is not generally advisable in our diverse context where vulnerable and others live closely with each other. It is not even easily practical, and in a situation where our young people in our 50s even have other comorbidities, it can be actually dangerous. So that kind of an approach to herd immunity, one must be very careful. Now there's another point, which is the serological tests, which Brahma alluded to. They look at population responses. They have extraordinary challenges in interpretation because potential false positives can skew the data hugely, but combined with very careful, structured verification methods and choice of populations, and that's something we've embarked on already, we can get an extent of exposure in populations very carefully done to see what level of exposure there is and how much immunity there is. So that needs to be done in a scientific manner and to see whether those who are exposed are actually immune. That seems, given the nature of this virus and what we know so far, it seems so far not likely that people who have got the disease once will get it again soon. They may get it in a longer period. What that longer period is, whether it's 6 months or 1 year or 10 years, we don't know.
Thank you.
Dr. Sonia is back, Dr. ASK.
Yes. So we were just talking about herd immunity and herd effect, and when we should be able to sort of envisage that emerging in communities. I think your volume was off.
I think Vijay may have answered that. Not in the near future, we're not going to get herd immunity because whatever studies have come from other countries have shown that 5 to 10%, even in the most severely affected regions, New York has shown the highest of 20% positivity of antibodies in the population. But other places in Germany, in California, in Italy, they've shown about anywhere between 2 to 10%, which means you still have 90% of your population susceptible, even when you have seen this huge increase in cases coming to hospitals. So I think we have to stop talking about herd immunity till we get a vaccine. There is no natural way to go into a herd immunity. It can only be through a vaccine.
And Soumya, there was a question for you specifically about oxygen therapy in Spain and what you think about its applications and the results of that.
That's an evolving area, and I think it's more a topic for the critical care physicians to discuss. It's not for the general public to discuss. There is clearly emerging evidence on the clinical manifestations of these patients, and there seem to be a group of people who do not need ventilation. They need oxygen. And it's important, I think, to recognize that, so that ventilation actually seems to be making some people worse. And certainly in our country, we don't want to put people unnecessarily on ventilators. We already have a shortage. And we know once you're on a ventilator, then it's really complex to manage. So it's quite important. So that's why we have to stress on oxygen availability even in district hospitals and things like that, because a lot of people can be saved with oxygen without necessarily needing ventilation. But oxygen is a very basic thing, and in many countries, even that's not available in the periphery.
Thank you. A lot of concern expressed in various quarters before the webinar and during the webinar that this lockdown is obviously having huge socioeconomic impact. There are not just issues of livelihood, there are issues of a pressure cooker effect with families being sort of closely tied together for days and weeks, and the resultant issues of child abuse and the abuse of the woman in the house. So there are a number of mental health effects and implications as well to this lockdown. So we are in the lockdown. I'd like a prescription from each one of you. How do we get out of this lockdown? And what's going to be the future? What's the kind of timeline we are seeing to this? What's the duration to some kind of normal? I understand it will be a manufactured normal, but some kind of normal where society gets its wheels turning again. How we are going to do it and what's the duration? So I think final words from all three of our eminent panelists, please.
You want me to start? I can start. I think there are four or five things that we will need to do. The first one I would say is data, and a really good analysis of data and a good interpretation of the data, not so much modeling. Even modeling can only be good if you feed in the right assumptions and the right data. So I think we have... The second I would say is doing the right public health things that are known to work in an infectious disease. So the contact tracing, the testing and isolation of cases, and the quarantining, either home quarantine or facility quarantine, depending on the situation. So expanding the capacity to test. The third is surveillance, which is actually part of data. If you can't test everybody, at least you must have a strong surveillance system that you can believe. So testing all admitted pneumonia cases and admitted influenza cases, ILI and SARI surveillance. And there are some indicators that we are putting out which will tell us like if you're at like acceptable levels. The fourth is, of course, health system readiness and preparation, making sure that you have the PPE, you have the oxygen, and you have the fifth is people's participation. And I think this so far has been the most neglected. So it's not just about giving information to people, but how do you get communities to participate in actually devising the solutions, and so that these solutions are sustainable. So in the rural areas, it would be involving, the Panchayati Raj institutions, the self-help groups, etc. In the urban areas, it would be different. But moving away from a coercive approach to a more participatory approach. And finally, I think that since we are learning about this all the time and new things are coming, of course, on the one side, the science part of it that Dr. Vijay spoke about, but also learning from what others are doing and learning from your own data. So putting in place that kind of feedback where there's ongoing sort of a research almost as embedded as part of programs, so that there are constant feedback loops where the learnings on what is working, what is not working. The lockdown itself, do we have data that it's worked in urban slums as opposed to localities which are in the middle class? I think there needs to be a very open look at the data to see in these 45 days of lockdown what has actually happened in different areas, and then I think re-looking at the definition of red zones, because there doesn't seem to be a denominator as far as I can see in the definition of the zones. It seems to be more based on numbers of cases, in which case cities will never be out of the red zone. I think you need a denominator both for testing to know whether you're testing adequately, and so per million or per lakh, and also in terms of how many new cases you're getting. And that has to be balanced against the capacity of the health system. So if you're getting 50 new cases, which your health system can easily manage, that's fine. You're able to live with that. So the goal cannot be to go to zero. The goal has to be to go to a place where you manage COVID and you manage everything else. Over.
Professor Mukherjee, would you like to go next?
Sure. So I think that my primary role, I see, of course, I'm a biostatistician, but I'm also an educator. And I worry tremendously about the students and the schools and colleges and universities that are closed, and students who have graciously, and professors who have valiantly transferred to a virtual mode of teaching and training our next generation. But this has not been equitable. How education is being imparted has not been equitable. Not everybody has access to Zoom and BlueJeans. I really worry about this equity in health, in economics, and in education. So I think that we need to, when we look at the data, what really bothers me, and Dr. Swaminathan actually articulated all the things that we need to do, but I'm just going to add to that, that the distribution of loss has not been even. And so we really, as a society, and even if I look at the data from Michigan Medicine, the outcome, the health outcomes, the COVID-19 outcomes in terms of mortality is not the same across all ancestry groups. So some people have lost more, and that's because of the structural and historic tenets of our society, where we have always had the haves and the have-nots. And the have-nots have definitely lost more. So we need to work on those problems even more. So the education and these inequities is something that we really want to, I really is resonating with me. And the second thing is that this family is being cooped up, and we are all in a very unprecedented circumstances. So it's important to really understand and emphasize not just on science, but humanity and art and the elevation and the greater meaning and purpose in our lives. Where, you know, if you think about why the singers, the amateur singers in balconies are becoming a symbol of support. So I think it's really, really important we really tap into humanity. We're talking about science and epidemiology, but also really reinforce what our race is all about, to take a leap beyond where we are, to really not feel so hopeless. In a sense, I feel that the students who are going out in the world, we had graduation, we had a virtual graduation with 150 students and their parents in a virtual room. But I think they're fortunate because they are going out in the world with a sense that what matters the most, it's not the career, it's the holistic view of life. So if we actually really go into a more spiritual, inspirational side, plus bolstered with science and data, I think we will get out of this with actually more knowledge. And I always say that the virus curves will peak and flatten. But if we can hold on to the lessons that we have learned during this time, humanity will be at its apex. And I'm very hopeful for that.
Thank you for a very inspirational and positive message for us to end on from you. Professor Vijay Raghavan, sir.
Well, I think Soumya and Brahma have summarized it so well. And I think the human aspect is very, very critical. If there's a lesson from how people have dealt post-pandemics, from previous pandemics, it is a sad lesson. Some people, some groups have learned, but by and large, communities tend to go back to business as usual. They forget the worst, and they, go back to a societal structure which doesn't help more equity and deals with the vulnerable in a more sensible manner. That's because for a variety of reasons. It's not that people are good or bad in that sense. There are economic, political, social pressures which overwhelm. In our situation, economically, we must, let me add to that point since Soumya and Brahma have pretty much covered everything else. Economically, there's a major lesson for India and for the world indeed. If you have a network of a global supply chain with only a few extremely powerful nodes and the other smaller nodes being very minor, then the collapse of one node, even temporarily, can cause global disruption on an enormous scale. That's what we have seen now. And that's what India has seen as a consequence of over a few decades of abrogating foundational manufacturing and industry to becoming an assembly superpower. There have been extraordinary exceptions to that, but by and large, we have been dependent on supply chains internationally. Therefore, our employment capability and so on has suffered because of that. As we come out of this, what is going to happen is that the economic superpowers are going to try and move manufacturing into their own locations so that their supply chains are not disrupted. India must preemptively have strategies which we are trying to develop nationally so that design and manufacturing has a strong presence at every kind of industry over here so that we become a foundational manufacturing hub which employs a significant number of our people, deals with the Indian market in addition to an export market. Therefore, unless countries like India, unless we become an important node, we will be very vulnerable economically also.
Thank you, sir. I think there are messages there for entrepreneurs and others involved in the wider economic network beyond health. So if I might briefly summarize before I hand back to CIC, I think what we are hearing is that this is going to be the long haul. The lockdown is perhaps just the beginning of the long haul. I think what I'm hearing is that we need to take sensible precautions, not just for ourselves, but around our communities. And we need to empower and educate our communities to take those precautions constantly. And every one of us must feel responsible to ensure that those precautions reach the last man on the last mile as well as possible. We need data. And I think the Arogya Setu app is a huge start. And I would encourage not just every one of us to download it, but I think that we need to encourage a lot of people to engage with the app so that we have a constant information being tracked. I don't think we should be afraid to report our symptoms. And at the same time, we should urge our governments and urge our communities not to stigmatize those who report symptoms. And finally, I think as we go through the long haul, as Professor Mukherjee and Professor Vijay Raghavan and Professor Sonia Swaminathan have suggested, we need to be empathetic to our communities, look at the more vulnerable, and ensure that we give access to children, women, elders, all the protection and all the support systems that they need, and also take care of the underprivileged among us. But it is definitely going to be a little bit of a long haul. With that, let me pass it back on to CIC to close. I'd like to thank all the panelists for their generous use of time and a lot of wisdom. Thank you so much.
Thank you so much, Krish.
Pleasure.
Let me invite our trustee, Mr. Lakshmi Narayan, to deliver the closing remarks and thank the panelists.
I have very little to say. It's been a fantastic discussion. We have run over time. We have a record number of participants and record number of questions. And for one, I've been educated tremendously. I'm sure all the others have been. Thank you very much for participating in this and making time for CIC. I'm unable to thank Bila Rajesh, but I'll convey our CIC's thanks to her also. Good evening and thank you once again.
Thanks, Lakshmi, and thanks to all the panelists.